Just wanted to welcome everybody for January's Complete Clinician Lifelong Learning Academy Masterclass. Excited this month to have Jared Powell joining us all the way from Australia in the future, a day ahead of us here in the US, but also in probably a lot better temperatures along the coast there in the Gold Coast of Australia. We this month have transitioned to a new platform from Kajabi, so hopefully for those who are listening, we're watching, haven't had too much of a hiccup to transition. We just feel it's like going to be a much better user experience. We're going to be able to do a lot more cool things, bring great speakers like Jared and others on, and get some interesting partnerships and stuff that we have to keep mum about now, but hopefully in the future we can let people know about, and got some exciting things to hopefully let you know in the not too distant future. But I won't talk too much. I'm going to pass the mic to you, Jared. First off, just wanted to thank you so much for spending some time with us tonight, generously sharing your time. I know you're a busy guy over there in Australia, and I know you, as you mentioned, you have a 10-month-old boy. So we also, a lot of us know how busy that is as well. So thanks for joining us tonight.
No worries, Mark, and all. Thank you very much for having me. Yeah, you're right. It's a beautiful day here on the Gold Coast in Australia. 32 degrees. Just got out of the surf, so hope there's not zinc on my nose. Anyway, if there is, you gotta stay sun smart. So I'm not too apologetic about that. So I'll just share my screen for all, because I've got a little bit of an intro in there for those who may not be aware of me. I'm just going to try and minimize everybody. Which I'm struggling to do a little bit. Anyway, we'll see how we go. Okay, so what I want to talk to you guys about today is sort of a topic that's pretty dear to my heart, which we're going to speak a little bit more about in a second. And it's kind of lifted from my shoulder course, which is the Shoulder Simple, Scientific and Modern. But before we get into that, I really just want to give you a bit of a brief overview as to who I am. So number one, I'm a dad and a husband, first and foremost. I'm very proud to serve that role. I'm chiefly a musculoskeletal clinician. So that comes first. I am a clinician at heart, and that is the main part of my professional identity. I am an educator as well. So I do teach at university here in Australia. I teach the shoulder. I also run my own shoulder workshops, both domestically in Australia and also internationally as well, which is a little bit harder to do in these COVID times. I'm also a researcher, so I'm currently doing a PhD investigating all things shoulder pain, and actually a little bit of this lecture tonight has been inspired from my PhD work. And I'm actually obsessed with sport and exercise and science. And so you're going to see a lot of these things coming through into the lecture this evening. So a little bit about what I do. So I love to play golf. There's a beautiful 9-iron hit to 6 foot, and I duly missed the putt, which I'm happy to talk about. I love to surf. I love to lift weights, hopefully a little bit better than this guy here. I love to pretentiously drink coffee, and I like to read and listen to books. And this is a book that I'm listening to at the moment called Our Mathematical Universe by Max Tegmark, which is pretty cool and fascinating listen. I'm just started it, so I'm not going to give too much away, but so far so good. So really the topic of discussion this evening for me is going to be centering upon this concept of strengthening, and specifically strengthening for shoulder pain. And I'm asking the question, have we been seduced by the hype? And certainly there is hype around strengthening, and I don't think that is being too dramatic. I think if we look anywhere, particularly on the social media platforms, it's always some form of strengthening that is advocated by woke clinicians such as ourselves. So let's go into it. And so, yes, I am going to challenge strengthening. And I know that is perhaps a controversial thing to do in 2021, but I'm going to give it a red hot go. So please listen And don't straw man my arguments if you can. I fully advocate exercise and resistance exercise for rehabilitation of all types of musculoskeletal pain presentations or musculoskeletal dysfunctions or whatever you want to call it. So I'm all in on resistance exercise and exercise therapy in general, but I think there is nuance to consider and we must consider it. I even dabble in a little bit of strengthening myself. Here's me a couple of years ago in better shape before the dad bod came on, doing some frightening upright rows, which are one of my favorite exercises to do. So coming to the core of my argument, I contend that any benefit to resistance exercise for rotator cuff related shoulder pain, which is what I like to call it, and I know that's a dirty word for some, we'll talk about that in a second. I think it goes beyond simple mechanical changes, and that includes increases in shoulder strength. Our clinical message, so the message that we as clinicians deliver to patients, must go beyond that all of your shoulder pain is chiefly due to weakness, and that to get you out of pain, all we have to do is get you strong. And I think that is a very reductive way to look at pain. So just setting the scene, non-surgical management is the principal approach to manage non-traumatic, and I would even contend on occasion traumatic rotator cuff related shoulder pain. We know that non-surgical management compares quite favorably to surgical management for previously called subacromial impingement syndrome, and also for rotator cuff tears of all sizes, but particularly small and medium atraumatic full thickness rotator cuff tears, and certainly partial thickness tears as well. So non-surgical management is the first line intervention to manage non-traumatic rotator cuff related shoulder pain. So this places us as physios or physical therapists, osteochiro, whatever you are, in a really strong and powerful position to manage people who present to us with shoulder pain. So just talking about rotator cuff related shoulder pain, whenever I mention the term rotator cuff related shoulder pain, it really should be taken to mean pain and dysfunction that is observed during elevation or typically external rotation of the shoulder, for which other conditions have been excluded. So this is a really crucial point. So we've excluded a stiff shoulder. So that's primarily a frozen shoulder or sort of advanced arthritic shoulder. We've excluded an unstable shoulder. We've excluded pain that's referring in to the shoulder itself, which is often due to perhaps sinister pathology or even just cervicogenic shoulder pain. So if we've removed all of those things from the equation, we're kind of left with this hypothesis of rotator cuff related shoulder pain. And so rotator cuff related shoulder pain for me is an umbrella term, and it's a hypothesis first and foremost. It includes classic pathoanatomical diagnoses such as subacromial bursitis, rotator cuff tendinopathy, partial thickness tears, full thickness tears, and even for me, I include non-traumatic AC joint issues and non-traumatic labral pathology as well. And so all of these classic pathoanatomical diagnoses for me come under this banner of rotator cuff related shoulder pain. So why do we use such a vague term? Why are we drawn to these vague terms such as rotator cuff related shoulder pain or non-specific low back pain or anterior knee pain or lateral hip pain? Well, because it's clinically challenging and or impossible to, and perhaps a philosophical crime, if we want to take it into the philosophical realm, to causally attribute an individual's pain, whatever that may be, to a structure or a couple of structures. And so this is a real reductive way of looking at things, where we take this complex and emergent phenomena such as pain, and we drill it down into one causal reason for their pain. And in physio, that's often looking at pathological structures or movement patterns, or dysfunctions, or whatever you want to call it. And so we have an abundance of evidence, observational evidence, that actually challenges this one-to-one association between tissue pathology, dysfunction, and the experience of shoulder pain. And so we know that we can easily see people who have no pain, have the exact amount of pathoanatomical changes when we look at them with MRI or ultrasound, and also postural dysfunctions or tightness here and there or weakness. We know that there isn't really a one-to-one association between observable physical properties of the body and this experience of pain. Moreover, how do we even determine clinically what structure is to blame? In the past sort of 5-10 years, perhaps, special tests have been challenged heavily in the shoulder, thanks to the work of chiefly Jeremy Lewis and also Paul Salam, which really debunks this whole concept of finding one causal structure as the reason for somebody's pain. It's kind of built on a house of cards that has all started to come tumbling down. Also, rotator cuff related shoulder pain is always a multi-dimensional experience. It's always at the mercy of cognitive, emotional, behavioral, socio-cultural factors, and many, many more. We cannot reduce this complex experience to one pathological structure within the shoulder that we see on our imaging. And I really love this infographic, I guess, or diagram from Lorimer back in 2007, which shows that pain is one output of a number of different sensory type experiences or previous experiences or cultural factors, and the context of the experience and beliefs, knowledge and logic and all of these things. Pain is sort of one output of all of these different inputs that are coming into the brain. And it's certainly not a result of simple sensory input or nociception alone. It is far more complex than that. And I know that I'm probably preaching to the converted by talking to you guys about this, but I really need to mention this to set up my conversation for this evening. So what method of non-surgical management is the most effective for rotator cuff related shoulder pain? Well, a paper came out last year by Louise Peters and co, which essentially found that exercise therapy plus or minus manual therapy, controversially, is the best and most effective non-surgical intervention that we can offer to somebody who presents to us with subacromial shoulder pain or rotator cuff related shoulder pain. So exercise intuitively makes sense. Again, it's all the rage these days to prescribe exercise, but controversially, manual therapy was deemed to perhaps add value to an exercise program. What type of exercise? Well, it all kind of works. We really have no evidence that one type of exercise is superior to another. It's all equivocal and ambiguous when you look through the literature. But the focus of the chat this evening for you and today for me is going to be about strengthening. And so if we look at strengthening and shoulder pain, if you simply just go in and type in strengthening and shoulder pain into PubMed, and you follow the timeline of papers being published featuring these terms, it's increasing in popularity. It's linear, if not exponentially increasing over the last 30 or 40 years. And if we extrapolate or broaden those search terms to strengthening and simply musculoskeletal pain, we see that it actually is exponentially increasing. So this concept or the hype of strengthening is not just in existence on the internet or on social media or Twitter or Instagram, it's in academic circles as well. There is a vast number of papers coming out looking at strengthening for musculoskeletal pain, and shoulder pain is not exempt from that. And so this is just another way of looking at that last diagram that I showed you. There is an actual exponential increase for the number of papers published featuring strengthening for musculoskeletal pain on PubMed over the last, probably since 2010, 2011, so over the last decade. Not to mention the social media gurus, and we won't mention anybody specifically. So does resistance exercise for musculoskeletal pain deserve this meteoric rise in attention? I think it does. I think resistance exercise or strengthening or strength training or resistance training, whatever the hell you want to call it, I think it does deserve our attention, and it has a pivotal role to play in our rehabilitation of a myriad of musculoskeletal pain presentations. But why? Well, firstly, it probably is the poly pill that we also desperately crave in healthcare. It's something that we can give to an individual, and we're pretty confident that it may actually influence positively many dimensions of their health. So not just musculoskeletal health, but certainly mental health, perhaps metabolic disease, cardiovascular disease, mental health, as I just alluded to, sleep, bone health, etc., etc. So it really does influence many aspects of human health. And again, we should harness strength training or resistance exercise because it's bloody good. In fact, the World Health Organization recommends that we should engage in some form of muscle strengthening at least a couple of times per week, if not more, as shown here by this paper, which came out in the BJSM in 2020. So we've got evidence that muscle strengthening is good for us, right? So if we sort of make this a little bit more specific in terms of pain or function in a rehabilitative sense, is it a panacea? Is it a one-stop fix-all kind of intervention? It's probably not. It certainly isn't a blunt instrument that we can use without critical thought and that we just apply thoughtlessly to everybody who presents to us with some form of pain. So what is the rationale for using resistance exercise for rotator cuff related shoulder pain? So I think a really nice way to set this up is to go through a clinical scenario. So you're a physical therapist. Somebody presents to you with shoulder pain that you hypothesize to be rotator cuff related shoulder pain. You have ruled out a frozen shoulder. You have ruled out an unstable shoulder. You have ruled out cervicogenic shoulder pain, for example, and you're not suspicious of any sinister pathology, and you don't think that person needs to rush out and have an orthopedic referral. You're left with the hypothesis of rotator cuff related shoulder pain. And because our clinical reasoning in physical therapy is massively embedded within the biomedical framework, and we cannot argue about that. That is our historic roots. And I don't want to sit here and bash on the biomedical model. It has been responsible for huge advancements in quality of life and longevity and a bunch of other things. And I'm a huge advocate for it, for disease. And if you fracture your leg, you probably need to have it fixed. But in terms of this concept of non-traumatic pain, it's falling woefully short and really hasn't done much for the rise in the pain pandemic over the last 20 or 30 years. The body is not a machine. So, but because we're embedded and we've been taught this at university, and this is still what we see, this is still the dominant model of pain. No matter what you see in your echo chambers or in your silos on social media, this is the dominant interpretation of pain. So we pursue a physical impairment, and for today's talk, that's shoulder weakness, chiefly external rotation weakness or abduction weakness. But it could be muscle tightness, or it could be faulty movement mechanics, or it could be upper cross syndrome, or it could be delayed activation of a muscle. What I'm trying to get at is it's a physical impairment that we can see and we can measure, and we apply an intervention to correct. So if we find weakness in the shoulder, we then apply an intervention to normalize that weakness, to correct that weakness. And this will often take the form of strengthening or resistance exercise to actually change the strength profile of that movement that you have deemed to be weak. And so this model of clinical thought or clinical reasoning is reductionist, and it reduces pain and dysfunction to simple, observable physical properties of the body. And again, I'm harping on it, but this is just not explaining the complexities of pain that we can see. But this is still the dominant model of how we're treating people with shoulder pain. And this is still being published on in 2021. And I can give you several articles that I've been reading recently, which makes me want to slap my face. And so in this example, we assume that there is this isomorphic relationship between strength, function, and pain. So if you look at the left-hand graph, every 1% or 10% of strength increase we get, we assume that that corresponds to an increase in function. And then on the right-hand side, it's the reciprocal, where every increase in shoulder strength we get, that corresponds to a decrease in shoulder pain. And so this is what isomorphic means. It means a one-to-one relationship between strength, function, and pain. And I want to challenge that interpretation or that narrative that we have around shoulder strength. So firstly, and this is probably a nice place to start, do people with rotator cuff related shoulder pain actually even exhibit alterations in their shoulder mechanics? So when I say mechanics, I mean scapular kinematics, I mean muscle timing, I mean shoulder strength primarily. So strength deficits, do strength deficits exist? Well, yeah, on average, strength deficits have been observed frequently in people with rotator cuff related shoulder pain of up to 43% in abduction and external rotation. So that is not an insignificant number. And this is comparing it to an asymptomatic population. So we're pretty confident that perhaps weakness plays some role in rotator cuff related shoulder pain. But the question becomes, must we normalize that weakness to change pain and dysfunction? We'll get to that in a moment. Deficits have also been observed in movements of the scapulothoracic muscles as well. Most of the weakness is found in the glenohumeral joint muscles. Scapular dyskinesis, we frequently see scapular dyskinesis, inverted commas, frequently in people with rotator cuff related shoulder pain. Now, this is another area of interest of mine. I'm not sure if it's a chicken and egg scenario here. My gut feel is that a scapular dyskinesis probably emerges as some sort of a compensatory mechanism to account for perhaps a reduction in shoulder strength. And so force is just simply redistributed to other aspects of the shoulder complex. I'm not convinced that scapular dyskinesis is a causal reason for the emergence of rotator cuff related shoulder pain. Perhaps again, it is 1/24 of every possible factor that can lead to the onset of shoulder pain. Again, must we change it to change pain? We also see scapular dyskinesis frequently in people without pain. And it is scapular dyskinesis does not mean that person has pain. And this is evidenced nicely here in this paper by Plummer in 2017, which shows that a control group was deemed to have scapular dyskinesis at 62% of the time, whereas the actual people with shoulder pain were found to have scapular dyskinesis 68% of the time. So no clinical or statistical significant difference between the two. Muscle timing and activity, people may have changes in their muscle activation and activity profiles. So this concept of an overactive upper trap may actually have some evidence for it. And there may be some delayed onset of the middle trap and lower trap, and also the serratus anterior as well. So this is kind of tenuous and certainly not high quality evidence, but there is papers out there, and this is a systematic review, which shows that perhaps there is a trend for these things to have emerged in people with rotator cuff related shoulder pain. And so a key question becomes, do improvements in shoulder mechanics always improve pain and function? And is pain and function reliant on changes in shoulder mechanics? So is shoulder mechanics the mediating variable of a successful outcome? So if you look at strength, improvements in strength in the best exercise regimen for rotator cuff related shoulder pain are about 20% maximum ceiling. And as I showed a couple of slides ago, strength deficits exist in some of up to 43%. So we're certainly not normalizing these reductions in strength in people with rotator cuff related shoulder pain. We're barely getting halfway there. And that's the best result. And most often, strength gains are hovering below 10% and are in fact clinically unimportant in many papers. So not even statistically better over a 12-week exercise intervention. So we need to sort of ask a question here. These very underwhelming gains in strength, what's it telling us? It's telling us that there's more to the story than simply increasing strength. What about scapular dyskinesis? It's quite clear now from an abundance of scientific evidence that we do not need to normalize scapular dyskinesis for pain and function to significantly improve. We have randomized control trials that show this. We have systematic reviews of randomized control trials that show this. It's kind of uncontroversial now to say that we do not have to change scapular dyskinesis to change pain and function. This is a horrifying point for many people. Muscle timing and activity, we do not need to change this to change pain. And I don't want to linger too much on this slide because I think that makes sense to us by now. So we're finding the same evidence in the lumbar spine as well. And this is a classic paper by Steger in 2012, or Steiger, which says that changes in pain and function are not attributed to changes in physical properties or physical profiles of the lumbar spine, including flexor, extensor, and endurance strength of the lumbar spine. So we're finding this is happening in the lumbar spine. And a paper which came out last year by Kevin Wernley, who was an Australian physio over in Perth in Western Australia in Peter O'Sullivan's group, changes in pain and also activity limitation are not due to changes in spinal movement profiles in people with non-specific low back pain. So we don't need to change movement mechanics in the lower back to materially and significantly change someone's pain and ability to participate in meaningful activity, which is the whole damn point of being a clinician. And in knee osteoarthritis, we're seeing the same thing. So I've got some preliminary data from this paper here, which hasn't been published yet, which shows that high intensity resistance exercise is superior to low intensity resistance exercise for strength, but not for pain and disability. So high intensity exercise probably confers an advantage for increasing strength, but it probably doesn't matter for pain and disability. And so we're seeing this across the board now. And so my aim is to shine a light on this for the shoulder, because I think it's been missing in a bunch of online conversations over the past 5 years. So we're seeing these limited changes in mechanical measures of the shoulder with resistance exercise. So I'm posing the question, does this challenge the relationship for shoulder strength between shoulder strength, function, and pain? Before we go any further, I'm sort of going to mention some limitations to my argument, because there are some valid limitations. So is the exercise we're prescribing underloaded and excessively cautious, perhaps explaining the lack of strength increases that we see in clinical trials? It is possible that a more stringent and adherent application to modern strength and conditioning principles, such as, and mostly including intensity, volume, and duration of training, would lead to enhanced strength gains. Now, I'm going to set this up. We need to do more research on this. And I fully admit that a better prescription of strength and conditioning or application of strength and conditioning principles, mainly including the variable of intensity, would probably lead to an increased result in strength gains. But does this mean it would have a correlate enhanced impact on pain and function? So just because somebody may get stronger with better strength and conditioning parameters of their program, does that automatically mean that that's going to actually influence pain and function as well? Well, I've actually got a couple of papers here that may challenge this logic. And Snape's asking me to prove it, so I will. And this paper here by Peter Malliaris, who is an Australian researcher from Melbourne, this paper came out in the last 2 or 3 months, and it's been a bit quiet. Nobody's talked too much about it online, which is fascinating. And what it shows is that high load and high volume exercise may be superior to low load and low volume exercise for function. Okay, so either high load or high volume exercise may be superior to low load or low volume. and especially when you put them together, so high load and high volume, it may be superior for function. High load and high volume exercise may not be superior to low load and low volume for pain. And so the concluding remark of this paper was that it is uncertain whether high load exercise or high volume exercise is superior to low load or low volume exercise for people with rotator cuff related shoulder pain. And so this challenges this notion that we're not loading people enough in our rehabilitation. If we would just load them up more, we'd have better results in these clinical trials. It doesn't seem to be the case when we look at the actual empirical data that we've got in the literature. Another paper here by Kim Ingerson in 2017 showed that progressive high load exercise, now this is high intensity, low volume. So this is progressing from like 15 rep max in week 1 to a 6 rep max in week 12. So progressively making that load higher over a 12-week rehabilitation regimen is not superior to low load exercise, which was low intensity, high volume for pain, function, and tendon vascularity. Who cares about that? But certainly not for pain and function. But the question must be asked in this paper here, and I think it's a valid question. Was the high load even high load? And I think that it probably wasn't, because it only got to 6 rep max for the last 2 weeks of the trial itself. So perhaps if they did a 1 to 6 rep max over the 12 weeks, we may have found a difference, certainly in strength, maybe in pain and function as well. But there were no difference between the high load and low load groups in strength gains either. So we're seeing that even if you prescribe high load exercise to people, they aren't getting any stronger versus people that we just prescribe low load exercise to. And there's certainly no difference in functional outcome between the two groups. So this notion that we're underloading people, and if we would just prescribe better strength and conditioning informed rehabilitation, that would make much more people stronger, and that would confer an advantage for pain and function. This seems to be unfounded when we look hard at the literature. So what we can deduce from this research is that a better prescription of resistance exercise based upon strength and conditioning may elucidate greater improvements in strength. It may, but certainly may not. It makes sense that it does. But remember, in the people that we see with pain, that they're a different cohort of people than simply somebody who's in a gym trying to get stronger. We need to factor in a bunch of different factors that may be inhibiting the increase in strength. And we're not going to talk about it today, but we know that pain inhibition and fear and all of these things can lead to a reduction in increase in strength. But we have no clear data to suggest that adhering to strength and conditioning principles has a significant impact on pain and function at this stage for the shoulder, for the knee, and for the lumbar spine. So have we been seduced by the hype of strengthening? And I think to answer this question, we need to kind of look back at our history. And I think our history as physical therapists, we've kind of been reeling from one panacea intervention to another over the last 20 or 30 years, be it manual therapy, be it postural correction, be it dry needling, be it acupuncture, be it pain neuroscience education, be it cognitive functional therapy. Everything comes out. We throw the baby out with the bathwater and we say, this is the thing that we've been waiting for. And I think we've done the same thing for strengthening as well. So just looking more specifically at manual therapy was once a mainstay of non-surgical management for not just rotator cuff related shoulder pain, but every damn pain presentation. Until, and I say until, I say that from an academic perspective and an evidence-based perspective, but I know there's many clinicians out there still using it as the cornerstone of their rehabilitation. I'm not judging anyone, until it failed to stand up to rigorous clinical trials. And so the latest systematic review that we have on rotator cuff related shoulder pain and manual therapy is that it may provide some additional benefit for pain, but it certainly doesn't provide any additional benefit for function. I'm okay for people to use manual therapy if they like, but it's certainly not supported by any rigorous evidence. And we have no evidence that we must apply it in every single consultation. It may be an adjunct to exercise. So, for example, what we've done, our clinical reasoning has been, we look at a tight structure or a stiff joint, and then we apply some sort of manual intervention that actually changes the stiffness or changes the movement profile of that joint, and we get it to play nicely, and then that results in an improvement in pain. This is a bit of a fallacious interpretation of what we're doing, how we're doing may work, and it's sort of taking out the whole context of an interaction. Anyway, we're not going to talk about that today as well. And I think we've done the same thing with posture and postural correction as well, either by manual or active techniques. So postural correction has been a diet and a staple of physios for many years. It's being heavily challenged now, specifically for the lower back. But there's also evidence that we need not worry too much about posture for the shoulder as well. So my reason for bringing these 2 points up is that we've done the same thing with manual therapy until evidence didn't really emerge supporting it. We've done the same thing with posture and postural correction until evidence didn't support that. I think we're going down the same pathway with strengthening, because the evidence out there is not really supporting that you must get stronger to change pain and function. So is shoulder strengthening, and it must be asked, another reductionist fad? And I think we should strongly consider that perhaps it is. This paper here by Josh Naunton, again, last year under Peter Maliaris's group, found, and this is quite alarming. This is alarming to me because I give bloody resistance exercise to every single person who comes in just about. Progressive and resisted exercise may offer benefit of uncertain clinical importance versus non-exercise-based interventions. So a systematic review and meta-analysis of randomized controlled trials shows that progressive and resisted exercise may not be significantly better than non-exercise-based interventions. But it is probably better than non-resisted and non-progressive exercise, because that has been shown to be not better or non-superior than non-exercise based interventions. So if you're giving non-resisted and non-progressive exercise, it is actually no better than giving someone a massage, according to this data here. So here's the effect sizes of this paper here, which shows that the black sort of diamond there that you can see shows that progressive and resisted exercise may offer benefit that is possibly or probably below the minimum clinically important difference compared to people not getting progressive or not getting progressive or resisted exercise. So this makes me skeptical and look at my own practice and my own bias. This was dumbfounding to me when I saw this paper come out only 6 or so months ago. So if we're gonna hold manual therapy to account whenever bad reviews come in saying that manual therapy doesn't work, we must do the same for resistance exercise and strengthening as well. And I know that resistance exercise and strengthening offers a bunch of other systemic or multi-system benefits, but for pain and function, we do need to scrutinize the evidence. I love this quote: "We are very good lawyers for our own mistakes, but very good judges for the mistakes of others." And I think when we see things that perhaps violate our worldview, we become damn good at defending it, but we're very good at criticizing other evidence that comes in, which confirms our worldview. I'm guilty of this every single day. It's something I'm trying to improve at. I'm probably failing at the moment though. Another thing I want to mention is rotator cuff related shoulder pain, a multidimensional condition. We know that pain is multidimensional. That's uncontroversial. But is this presentation of rotator cuff related shoulder pain itself a multidimensional condition? We've got evidence or emerging evidence to suggest that it probably is. The emergence of rotator cuff related shoulder pain is not due to one variable or one dimension of somebody's experience. It's due to many factors. It's due to pathoanatomy, it's due to loading history, it's due to age, it's due to genetics, it's due to central nervous system factors, it's due to cognitive, emotional, and behavioral factors. Just to name a few, it is due to occupational and social factors, it is due to socio-cultural factors, it is due to many, many things. And we have evidence, empirical data to support that. It's even due to sleep as well. And so I think we just need to get away from this obsession with tissue and structure and strength and kinematics and all the things that we can see. Another question I'm going to ask is shoulder strength strongly associated with the severity of shoulder pain or shoulder function? So what I mean here is, the weaker you are, does that mean you have more pain or more dysfunction? No. Those with more pain or dysfunction do not have more shoulder weakness. It's the same thing with pain, right? Like if you cut somebody's skin by 1 centimeter, by cutting it 2 centimeters, does it double their pain? It does not. So if you halve somebody's strength, that does not lead to more pain or more dysfunction. We've got really good contemporary data that actually suggests that strength and tissue pathoanatomy is not really related to the severity of somebody's shoulder pain. There is more to rotator cuff related shoulder pain than strength. And I know that I'm repeating myself here, but I'm trying to make a point. So the same could be said for resistance exercise as well. There is more to rotator cuff related shoulder pain than strength. And there's more to resistance exercise than simple strength. And a lot of you have probably been yelling through the screen to try and say, well, what about all the other stuff that resistance exercise does? And I'm listening. I can hear you. Resistance exercise may have a hypoalgesic effect. Respect. I absolutely respect that. It probably improves health-related quality of life. That's the most important point for me. And that's really all that I care about. Maybe it increases self-efficacy and probably more specifically confidence. Self-efficacy, hard to change. I like Chad Cook's quote, self-efficacy is what people come to you with, not what you change. And I think that is probably important. Maybe resistance exercise or strengthening or exercise in general can change self-efficacy a little bit, but I think more importantly, it can damn sure increase confidence to move. Does it influence systemic inflammatory markers? We have evidence to say that it does, for sure. It can sort of lead to an improvement in our metabolic health and our systemic inflammatory health, which is important. Physiological factors are associated with pain. We have evidence that substance P and interleukins and tumor necrosis factor and all these things are present at an elevated rate in people with rotator cuff related shoulder pain. So could simply moving the shoulder under a loaded environment or loaded parameters actually change this? Maybe. It actually can reduce symptoms of anxiety, which is fantastic as well. Everybody's anxious about their pain. That's the whole point of pain. It is to make us anxious. So it's protective and it serves an evolutionary point or role. Maybe it simply provides a distraction while time or nature does its thing. And that's a reasonable thing for exercise or movement or any form of distraction to actually serve as a role for pain reduction. And I think more importantly, and I think this space has a lot of progress to make, is I think it probably prompts a reevaluation of pain. So it has this evaluative quality. It actually prompts our system, our organism to look at itself. And if you want to look at it from a predictive processing lens or something like that, it may force us to update our beliefs or our predictions about certain movements. And I think that must be considered, and research needs to be done looking at the role of resistance exercise or exercise in general from an evaluative perspective. So these factors at the very minimum, and there's many more, should always be considered and probably mentioned whenever resistance exercise is utilized for a person with rotator cuff related shoulder pain. We should zoom out. We've got to see the forest from the trees, and we shouldn't get stuck in looking at just these little things that we can measure with our goniometers or our dynamometers or our isokinetic machines or even our outcome measures or whatever we have. We love it. and we're told to do it by insurance companies. So I understand we're kind of in between a rock and a hard place, but our clinical reasoning must go beyond that. So I want to integrate resistance exercise into a modern understanding of pain. We know that pain is much more than a linear readout of the state of the peripheral tissue. We know that. That's unequivocal. That's inarguable. We should apply the same logic to rotator cuff related shoulder pain as well. It's far more than simple strength or movement profiles. It's a multi-dimensional experience. Therefore, resistance exercise may influence somebody at absolute multi-dimensional or many different biopsychosocial domains. Really important. Okay, in closing, resistance exercise is at risk, and I think it already has become a blunt instrument. It's used without critical thought, and it's used as a panacea to help everybody with any particular pain presentation in any demographic. Even if they've had a bad experience with it before in the past, we just say, toughen up and do it. Trust me, it's good for you. I think we need to be more selective and have more nuanced approach to it. This is the exact type of reductionist biomedical thinking we have spent 20 years trying to progress from. But we've been fooled again. And so we need to change it. We need to appreciate the complexity of human beings, firstly, and also pain, and certainly rotator cuff related shoulder pain. Don't fall for the new fad or the new gimmick that comes out, even if strengthening is an active intervention. I'm all for active interventions, but we mustn't elevate it to godlike or deify it because it's just another intervention. Resistance exercise has a pivotal role to play in the management of rotator cuff related shoulder pain, but there is nuance to consider. We must have a nuanced approach. All right, I'm finished. Thank you for listening to my rant. For more info, check out website, Instagram, whatever you want. I've got an online course as well. And for all you guys, I'm giving you a $100 discount. The discount code is PAINCARE. And so that's in American dollars, it comes down to about bloody 10 Australian dollars or something. So I'm sure you can all afford it given the exchange rates at the moment. So there you go. And I'll take some questions now.